Howdy and hello. Hope you can hear me. I'm going to make sure that you can hear me because I guess the last time I recorded a video, I needed to do a new screen share and it didn't work out as great as I hoped. I thought I could just switch over since I was already screen sharing, but you have to do a new share every time. This week we have a clinical connection. I'm a big fan of illustrating what we talk about in class. Again, there's some good things about teaching online. I'm not going to lie. There's some less than desirable things teaching online. But just so you know that, like, yeah, I actually do this for a living, and I do this at WT. Um, I think that doing case studies is very important. I think we need to introduce y'all to case studies earlier than what a lot of people do. If we want you to eventually be able to work with people who are essentially cases, you got to be able to read and walk through cases. So this year, since voice was online, we've already done a clinical connection where I did a case study. Before, and this one is a little bit different. This one ties into Presbyphonia. So this is actually a very old case. Names have been changed, of course. But this is right when I was starting to do voice. It was essentially right around, I think, when maybe I'd been at WT and doing voice for about a year. So I'm a big fan. If it takes you about 2-ish years to really, really know what you're doing, it doesn't mean that you're not skilled or competent, but this was probably right after my first year at WT and working with this patient. We were still on main campus. And so your PowerPoint slides will talk about using Forte. That's the randomized controlled trial. So in the best world, best circumstance, that's what you should do if they're stimulable. But I wasn't trained in Forte yet. So we had to figure out some other ways to help this patient. And so here is kind of a little case study of a patient of mine with Presbyphonia. And we're going to call her Julia. And no, this is not actually her picture. For those of you who don't know, this is a picture of Julia Child, but this patient kind of fit the profile of Julia Child, which is when I decided to pick her for teaching purposes. I've used this case actually in undergrad. I used to use it in grad class. I just thought it would be funny because she did have a lot in common with Julia Child. So she was a 75-year-old female, and she was a retired home economics or family consumer science teacher. She had her master's degree, and so she was a part-time instructor or adjunct faculty at a community college. And so she helped with the culinary arts program. And so that was kind of like her Christmas money, her vacation money, her side hustle. Anyway, super sweet lady. But her chief complaint really was that she was getting older, and I don't know how many of you have ever taken like an actual cooking class, or if you took family consumer sciences like food technology and nutrition. It can get very loud. I mean, anybody who's cooked or worked in a restaurant as a waiter, even when you go to the kitchen, it's loud. And so, of course, she had all these students, and she was having a hard time being understood during cooking class. And she had her hearing screen. Actually, she had really good hearing. She didn't have presbycusis that I remember. And so her problem really was that she knew that something was going on with her voice and that it wasn't the students, it was her. I think lots of years of teaching high school home ec and family consumer sciences, as well as just where she was in life, had kind of made her realize, that there are certain things that just aren't about students, it's about the teacher. Some of her signs and symptoms of a voice problem, including that she had vocal fatigue. So she felt like towards the end of a teaching day, because how she taught was basically 2 days a week. She basically taught labs, more or less. So they would kind of have their actual textbook stuff. And then there were days where she would come in and do labs about 2 days a week. And so at the end of those labs, she kind of endorsed that her voice felt tired. Occasionally, she'd have a phonic break. So it wasn't a pitch break. It would mean that every once in a while, these breaks would go away. She was not known for having a breath equality, and a breath equality was kind of emerging. And she also had started talking in a little bit of a higher pitch for her. So a little bit, she was referred to us from an ENT, but she was really very healthy for her age. She did have some high blood pressure that she managed with medications. She had reflux disease, which, my grandmother always used to say, never trust a skinny cook. A cook that don't eat, I don't know that I trust them very much. It's kind of like when my wife watches these British baking shows, and there's this one twig of a woman who, I don't know, I don't trust her as much as I trust the other lady who looks like Mrs. Doubtfire. The other Mrs. Doubtfire lady, I trust that she knows what some cake is. She had some reflux that she really wasn't good about taking her meds on, but she ate very rich, fatty foods. I mean, again, when you're a cooking teacher, you're not going to just make salad. You're going to make very rich food. So she did had some reflux, but really she didn't smoke. She had an occasional glass of wine, again, being a cook. But I mean, really, she walked. By no means was she running any marathons, but for her age, she really was, other than the hypertension and reflux. There wasn't really any major concerns that we could find in her history with what we were given, nor per her report. But a few things. As I mentioned, she enjoyed herself a couple beverages of alcohol. She had about 3 glasses of wine a month, is kind of what she said. She did not drink enough fluids, period. Especially, she drank only about 8 ounces of water in a 24-hour period. Now that doesn't mean that everybody's got to drink, 72 or a gallon of water. Some people are on medications that's contraindicated, but still that's not a lot of water. She had about 2 cups of coffee on average in about 24 hours. That's pretty normal. But then nothing else. So she didn't drink a lot of fluids, not even like green tea. She lived with her sister. She was widowed. And so she had since, both her sister and her husbands had since passed away. And so they had just decided, let's take care of one another and move in. So she lived with her sister, and she enjoyed playing bridge. She had a great social life for her age and no remarkable surgeries. So we definitely knew that some of this had to be age related, just early on. Medical exam, again, she started seeing these voice problems becoming more prominent about 4 months prior to seeking a medical consult. She went to, I've changed the ENT's name. She went to an ENT. Really, the vocal folds were adducting and abducting very grossly, so they were within functional limits. The ENT's report said no lesions, but there was bowing and thinning, and then that glottal gap or glottal insufficiency. So she also commented that, again, because of the history of GERD, they could see some pachydermia, or it's basically where the tissue starts kind of getting scaly and even discolored due to the acid. It's called pachydermia because it's the same as, say, a rhinoceros or an elephant, which are pachyderms or gray skins. You could definitely tell that some of that acid was coming up and settling on the arytenoids and causing them to get a little bit discolored and irritated. So this is not Julia's audio and video clip sample. Again, I'm kind of I'm going to be vulnerable and say sometimes I don't think I knew what I was doing those first couple of years. This is more of an example of someone very similar. She's a little bit more presbyphonic, and her strobe over here, this is from a casebook resource. She's a little bit more severe than Julia was, but this is kind of what presbyphonia sounds like in an elderly woman. Here we go.
The blue spot is the key again. How hard did he hit him? We were away a year ago. We eat eggs every Easter. My mama makes lemon muffins. Peter will keep at the peak.
Hear that kind of breath escape.
My voice, after not talking for a while, starts out kind of good. The more I talk, the worse it gets. It kind of cracks and goes up and down. Gets harder to get the words out.
Yeah. So, and then this is the same patient's strobe. One thing I don't like about this video is that the clinician, and again, I wish I could demonstrate better face to face, but really the clinician, you can hear the clinician almost as good as you can hear the patient, which we have to be mindful about that. So, but anyway, I'll point out a few things to you with the video.
Good. Real low in your voice. He. Do that again. He. 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 Do that as loud as you can. He. Real loud. Good. Try again, loud. He. Loud. He. Good. Try to do it low in your voice, loud. He. Do that again. Breathe. He. As long as you can. Deep breath. He.
Do you notice that she
Breathe.
never gets
Say
good
he.
closure?
He. Take a breath in between. He.
She gets better closure, but in this video, she never gets good closure. She's probably doing a rigid, so there's not much else they could do. But prominence of that glottal gap, if you will, or glottal insufficiency, very prominent. And so that's what's contributing to that kind of breathy, air escaping behavior. So what did I do? After my case review and interview with the patient, and again, these are abbreviated Cliff Notes versions of the report. Kate V for spontaneous speech. So overall, I did not perceive her to be that dysphonic, very mildly, kind of closer to that mild to moderate range, 38 out of 100, but consistently. Probably should have put her breathiness marker. I think it was kind of maybe a little bit higher. But really no strain perceived and no roughness perceived. When I scoped her, I try to do a rigid and a flexible scope simply because there's pros and cons for both. But overall, the impressions of the exam was that the exam was remarkable for a mild spindle-shaped glottal gap in sustained vowel and sentences, atrophy of vocal folds contributing to prominence of vocal processes. And then finally, again, laryngeal functioning. The most remarkable finding was that in conversation, her vocal intensity was 58.85 decibels SPL. So in acoustically perfect environment, you could hear her in conversation, but we don't live and work in functioning in acoustically perfect situations. So really needs to probably be a little bit, her natural fundamental intensity needs to be up a little bit more. So it didn't surprise me that with clashing pans, refrigerators open, blenders running, students asking questions, phones going off, that maybe she was having to feel like she was having to really yell to be heard. So I diagnosed her with, of course, dysphonia R49.0. We described this as mild presbyphonia characterized by age-related changes to the larynx. Predominantly that glottal gap was the main thing. Again, I also mentioned that there was some atrophy I noticed of those vocal processes being more observed. So our plan was, she again wanted to keep teaching. She wasn't willing to give it up, not really interested, and really not a good candidate for surgery. So again, I was new in what I was doing. So I said, let's do voice therapy, and you come once a week for about 45 minutes to an hour. I needed to kind of do additional stimulability testing to see what of the techniques I was trained in and knew how to do, that she would respond to. And then really we had pretty much just two voice therapy goals. We wanted to increase her vocal intensity by reducing prevalence of glottal gap and then implement vocal hygiene strategies. So, what did her course of treatment or what did therapy kind of look like? You'll hear that term course of treatment or length of stay. Length of stay is more geared towards like how long they've been in the hospital, or course of care. When you're summarizing kind of the what did everybody's therapy look like or what did her therapy look like, you might say course of treatment. So, when she returned after that initial evaluation, I'm a big fan of making sure the patient understands their diagnosis, understands what we did with them, answer any question we have. So really, we educated her. And then the next thing is I continued my stimulability testing. And really what I found was that she did really well with vocal function exercises and resonant voice. So we were going to use both of those. In the next session, I'm a big fan of patients understanding what's going on with their voice, how the voice works, kind of the biomechanics. So for about a third of the session, I provided some illustrations, walked her through, helped her label vocal anatomy, the vocal subsystems, how to create a voice. I'm not a big fan of naming and labeling things when I'm doing stimulability testing. I believe that if I cause patients to think too much about it, they'll get too much in their head. So we basically introduced vocal function exercises to help with that glottal closure. That seemed to be the best thing that kind of eliminated that breath equality. So I demonstrated them. I taught her. You'll see I'm not a big fan with exercise programs. I'm a big fan of no more than spending about 3 sessions on them if we can. Then resonant voice, weirdly, I wanted her to do that to kind of help with the quality and projection so she would feel like she had some oomph behind her voice. We did Dr. Stemple's resonant voice program. I wasn't trained in Dr. Vertellini Abbott's protocol yet, so he uses in mostly stages. I think it's 7 stages, maybe 8 stages. And so I try to go with this patient, I try to go as quick as I could. So the next session, we basically wanted to kind of test or assess her understanding of the problem. So did she understand what presbyphonia was? Did she understand how to create a voice? And there's a typo there, I just realized. And I used to teach English, so there you go. Vocal function exercises, again, I wanted to see her do them, and I was going to coach and give her feedback on them, and then see how she carried over with resonant voice therapy for stage 1 and 2. We went ahead and addressed 3 and 4. Starting session 4, we kind of discussed probable and likely vocal hygiene strategies. I'm not the biggest fan of recommending everything. Based on my assessment, I kind of find which ones I think the patient is most open to or what are going to give them the most bang for their buck. And those are the ones I want to recommend and see if they trial and if they're happy with them. So the main one really is I did want her to either invest a little bit of money on her own or talk to the college about some sort of amplification system. The other ones like her reflux, be mindful, drink more water, etc. But again, at her age, I don't know that I'm going to fight that battle really. I kind of saw how independent and proficient she was for those vocal function exercises. And then really session 4 and session 5 were almost like repeats of one another. That often happens. Sometimes you do need to go through and have the same plan and do it twice to really make sure it sticks. When she came for session 6, we heard this wonderful, beautiful, great voice, really. And it really made me say, let's kind of review everything, but really we need to reassess what's going on. She felt she had met her goals for the most part, but we needed some actual formal data. And so we determined that instead of her coming the next week, we would wait 2 weeks. And then we would decide based on the data, do we discharge or do we continue or do we modify, etc. So session 7 ended up being her discharge session. Kind of did a mini reeval. The overall severity was a 7 out of 100. So really, that's me being super, super picky. I went ahead and scoped her really quick, using the strategy she had done. She'd been really compliant with the vocal function exercises. That glottal gap was much reduced and almost unremarkable. If I didn't know she had one before, I probably wouldn't be biased and really not done it. Really even said it was unremarkable. It wasn't present anymore. She used an amplification system. So the college did have one already that she could use. So that was good. Also, it was surprising. She realized that maybe with bridge playing and teaching and everything else and living with her sister, maybe she needed to do a little bit of vocal rest. So again, that was a strategy we introduced. It wasn't one that I was really adamant on, but she realized that she probably needs some time to just not talk. So some modified vocal rest was really good. And then when we assessed her vocal intensity, she was up quite a bit, 67.58 decibels for just comfortable, normal teaching. So not even trying to project her voice. So again, as I've told you, this case, it kind of fit the textbook situation. I keep on debating if I'm going to start showing cases of like, oh gosh, what goes wrong in voice therapy. But for right now, I want to sell you on voice therapy is fun. Voice therapy works. It's short term. It matters to people. But I guess my big thoughts and conclusions on this is, again, we all are going to get old. And we're all going to want to do things that really we're starting to have a harder time to do. And so with Julia, she was very motivated and she was very gregarious and she was very appreciative, and she went on with her life and she did good in voice therapy. I think she also was very realistic with the outcomes. Any other thoughts and conclusions I'd love to hear your take on. Please don't be afraid to reach out, and keep on working hard and have a good day. Bye.